Hey, what's up guys? It's Matt, and I'm back here on the couch today, and I wanted to shoot this. Apologies ahead of time, this might be kind of a long video. But basically today I want to talk about my last month. I've been working for right about 5 weeks now, and it's been going great. So I was supposed to get 6 weeks of orientation, but just due to scheduling shortages, basically a shortage of preceptors, not so much staffing shortages. I basically had a night where my preceptor had to take a assignment basically, because we had a therapist who had an emergency, had to leave. So I was left on my own about halfway through first rounds. So by like 9:30 I was on my own that night. On top of being on my own, I actually wound up also having 2 students come with me. You know, whether or not that was a help or not, I mean, it was fine. It was just a chance for basically me to focus on charting while the students were actually taking care of all of the patient care stuff. So it wound up being okay. And then my very next shift, which there was some confusion because the charge that night said that was supposed to be my last night. I thought I had another week, so I'm kind of confused about that. It's not super important though. Basically, we had no one. Had I been assigned a preceptor, we would have probably had a very, very large assignment, which would kind of defeat the purpose of having the preceptor, because when the assignments are too big, you wind up splitting it anyway. And so as the new hire / new grad, I wouldn't get the same experience. So the charge wound up just basically saying, sorry, but you'll be on your own tonight. And again, I didn't have a massive section, and everyone was pretty good about calling help. That shift actually wound up starting with a code first thing at 7 o'clock. So I get to work at 6:30. I'm usually out right around 7 to get to the Pyxis to start drawing my drugs for my first set, and there was a code like at 7:05. So I hadn't even drawn my first minute. I just logged into a Pyxis when I heard the code called. It was just down the hallway. And that's where I spent the first like 35-40 minutes of my shift doing that. So, but everyone's really good about calling and helping out, especially the ones when they know that like we're new grads or new hires. People call, try to follow up with you and make sure you're doing okay. So the shift actually wound up going reasonably well. And then my very next shift, again, I was on my own, had my own section, was just able to do my thing, you know, try not to give away too many treatments, you know, that way I can just kind of stay in there. And then my very last shift actually I had on my own, again, went well. We actually had a float, so a day person came in at night to do kind of float work through the first rounds to help out, since the nights seemingly feel like they've been a little short. So it's easy, you know, to give away some of your easy treatments, your like once a shift puffs, your BID puff treatments like your Symbicorts, or like BiPAP checks, like home BiPAP setups for nocturnal BiPAP. So it's easy to give away little stuff like that so you could focus on all your Q4s and Q6s. So really my reflection over this last month, from my preceptorship to my first few shifts on my own, it's kind of flown by, I guess. It's been a good experience. You definitely have to learn your time management and be able to bounce back, especially from situations like having a code at the very beginning of your shift, and you know that's a priority. Even though I'm not a part of a rapid response team or a code team or anything like that, I was on the unit. Anyone who is reasonably available should try to make their way over there to see where they can help. I happened to be the first RT there because it was just down the hall from the unit I was starting on. I got in there immediately. We got the bag hooked up. I started bagging. A student was actually there that night who got there, so I kind of brought her back so she could bag while I held. And then once our charge and ICU therapist got there to start running the intubation, I moved places with them so they could continue to bag, and then I got in line to start compressions. And that way relieve some of the nurses who also respond because, more than just that patient's nurse will respond. And 7 o'clock is right when nurses start to do their change of shift. So it's nice just to free up them to get them out so they can finish doing their thing, get their stuff going for that night. And then I wound up doing a few rounds of compressions till we got the patient stabilized, transferred out to the ICU. So you have to be able to bounce back from that when you're put 30 to 40 minutes off your schedule. You have to figure out what you need to do, prioritize, communicate with your team, potentially with the nurses. Sometimes they'll call if a patient knows they're supposed to get treatment. If the patient really does need those Q4s, being just openly communicating with everyone apart and in that line, and usually it's okay. And don't be afraid. I think as a new grad, one of the things is you're afraid to mark missed or things in the MAR, like you think you need to get them all done. That's a situation where if you missed, and usually there's some sort of a reason code like missed due to emergency, and that's what you would chart. You missed it due to an emergency. If you tried to get back, it's one thing. But obviously, if you're really not getting a chance to start until closer to second round, sometimes it's just better to mark it that way. If the patient really needs it, the nurse will call you and say, hey, my patient's in a lot of distress. Can you come by? And obviously you can prioritize your list a little differently. So doing your best to triage, and I know it's hard. One thing I've noticed is sometimes you'll get PRN calls. Doctors almost always have PRNs for patients who maybe aren't scheduled. And it'll usually be for shortness of breath or dyspnea. But we have so many cardiac patients who don't get a benefit from it, so you have to be able to prioritize that. I often just go and do them anyway because it makes the nurse happy, it makes the patient happy if it's not too much of a burden. But if it's going to be a huge burden on me, like I'll have no problem telling them. You learn really quick to be like, hey, listen, I'm a little caught up right now, especially when they're calling for like an as needed on a patient who's scheduled. That's a little annoying too. Sometimes, it just takes a while. Treatment links differ, If you have someone getting Atrovent, Pulmicort, and Brovana, even if you have a Fastneb or a ban, it's like that still takes a few minutes. It's not like running just someone who's getting an albuterol treatment. You just do the best you can, and eventually you start to get a flow. And at this point, I feel like I have a flow, and the flow only gets better and better and better. So my time precepting really helped. Now that I'm on my own, you get a little nervous sometimes, especially when you don't know where you're going to be scheduled. To be honest, I'm super nervous about my first time having to be scheduled by myself in the ED. Mostly because the ED covers so much. But otherwise, it's been absolutely amazing. To feel like you have some control to make your recommendations. To see when you have a patient with an issue and that you have this power through the doctor's orders. The doctors will normally order some sort of oxygen order and have it very open-ended, like titrate to keep sats above 90 or whatever. And when you have a patient like on a nasal cannula who the nurses told you they have to bump it up, and it's like, well, I made a decision the other day to put a patient on an oxy mask instead because I noticed the patient was doing a lot more mouth breathing. So even though you're building a nice reservoir with a nasal cannula, I think an oxy mask was going to be better to help maintain his sats. And even a week later, coming back to that patient again on the oxy mask, still playing with the titration. So to know that to feel like you were looked at to make that decision feels good. Making decisions to change a patient from like a trach patient from a cool aerosol to a heated high flow because of secretions, and talking to the nurse, be like, we need to talk to a doctor, maybe get this ordered because they're having a lot of secretions. The cool aerosol is fine, but I think heated high flow would do better. Especially patients who, fresh trachs, that they're not used to it, it's sensitive, it's hard to put them on other things. Heated high flow, I think, is a little underutilized and is a great piece of equipment, even for patients who don't need oxygenation. I've read something recently where a doctor had said that using a heated high flow on anything less than like 30% is useless, and that's absolute garbage. I don't know what doctor said that. Heated high flow, I've seen a trach patient on just 10 liters, 37 degrees, and 21%, because they don't need oxygenation. They just need some flow help. The heat, since you're bypassing that upper airway, will help with any secretions they have. So heated high flow, like, don't hesitate. It's legit. So yeah, as far as other things I've learned, I guess, in such a short time from being a student, number one, and I want to say it was Amy at Breathe Easy was talking about it. There's a lot more focus on charting. So now that you're working and you're not a student, as a student, you have one job, and that is focusing on the patient. Your patient care, your bedside manner, a little bit of your flow. I mean, getting in there, getting their oxygen, doing everything in a certain order. A nice thorough assessment if you're able to get your auscultation, all your vitals that you need, getting the treatment ready, setting up the neb if there's not one set up, all that kind of stuff. As a student, that's your focus, to learn how to do the respiratory side. Once you're working, it's assumed that you've graduated, you've passed your exams, you've got a license, you know how to do respiratory. Your job is learning how to chart right, how to chart efficiently, while still doing all the respiratory stuff. Managing your productivity is a big deal. Being realistic with your productivity. Like, yes, a treatment only takes, like, if someone's just getting an albuterol treatment, in a neb, and you're running it at 6 to 8 liters, it takes what? Like anywhere 5 to 7 minutes to run through completely. You can't just chart 7 minutes as productivity, because it took you time to draw that mid from the Pyxis or AccuDose or however your facility's set up to get your drugs. It took you time to walk to the patient's room. The time it takes to commute, I guess, from your drug dispensing machine to the patient's room, or from room to room if you're drawing multiple drugs. You're not standing around doing nothing. You're moving on to the next patient. That's time you have to account for your productivity's sake. And all the time in your room, your assessment time. Even if you got your flow in, you get in, you got that pulse ox on, you're on the computer, scan the patient, scan the meds, it's all good, you start going. You have to account for all the time. So the reality is that even a real basic neb, a duo or an albuterol or something, is really at its best like 10 minutes. If you're charting less than 10 minutes, you're cutting your productivity short. You may look at it like, well, I'm being really efficient, but not really, because what's going to happen is your productivity is going to be looked at on a large scale from outside of the department usually. Like, I don't know if a manager oversees it or whatever, but that's how they dictate the ability to do things like add positions, add full-time positions, add per diem positions. And if you're knocking out crazy loads and minimum times, and you're being efficient, even you're really just selling yourself short. You're selling yourself the opportunity to have help to shrink your loads. Always track your time, track it properly. But yeah, charting is a really, really big deal. So the night I had those 2 students, what was nice was I could focus on my charting, considering it was my first night, kind of being on my own and not having someone watching my charting to make sure it's not totally messed up. So they could focus on patient care. I could oversee what they're doing. It was mostly floor treatments. It wasn't like anything terrible was going to happen. But I was there in the room focusing on my charting. They were focusing on the patient, and I could kind of guide them. We had a few unique treatments too. It was my first tobramycin treatment, so I knew to grab a new neb and set that up. Since that's kind of tobramycin is always in a separate neb from anything else. And I did make the mistake of bringing a regular neb, not having a fast neb to run the Toby treatment. So we were in there for felt like 30 minutes, waiting for all this medication to run through. But again, that's one of those things that you learn as you go. You remember certain things, you forget other things. It's okay. So some other things that I felt like I've learned in my time here. So the differences, in real high speed versus being a student. You're managing your time, you're managing your charting. A lot of your focus is on charting. Other things, I've learned a lot about respiratory, things that you wouldn't have known, I guess, if you weren't working. You may think you know, you say, hey, I really enjoyed this part of school or this semester or this unit or whatever. And even when your clinical time exposed to some of those, you may say like, oh man, I really liked that. Then you get in the real world and you realize as a student, you're kind of catered to, your hands held, you're not really at the disposal of everything. And one of the big things that I learned is I really don't like pediatrics that much. It's not that I don't like helping kids, and it's not that I can't deal with parents, I guess. It's just the way pediatrics are done in terms of how their treatments are scheduled and that kind of thing. It's just kind of annoying, to be honest with you. And I know it's what's best for the kids, but that's certainly one aspect I've learned since I've started working that I really just don't enjoy, and it may get better as I go. But right now, one of the big things is that since we still haven't hit our fast season, or I guess crazy season for flu and RSV and all that stuff, typically whoever's covering the ED has to cover both the pediatric ED and the adult ED, as well as usually another part of an assignment. So like we have orthopedics and PACU that are over in what we call the tower too. And so you're typically covering that. And so as a night shifter, we normally don't have a whole lot going on up there. Maybe like an inhaler treatment, maybe some overnight, just like home unit BiPAPs or CPAPs. But having to run back and forth from an adult ED to a pediatric ED, which are not attached, and right now there's construction too going on, so hallways are blocked, so you're having to like walk extra long ways around or cut through departments to try to get back and forth. And then you get over to pediatrics and the doctors will want that Q15 or Q20 times 2 or times 3. And certain doctors don't want you to back-to-back them or all at once them. They want you to legitimately wait 20 minutes. And it's like, when you get 2 or 3 of those, that's great. You're trying to like, okay, that's easy enough. You got 2 or 3, just start one. Okay, go start the next one. Okay, go start that next one. And then that should be enough time to go back and start the first one's second treatment, and then the second one. And that's all fine and dandy until you get called to and you got one-time treatments in the ED. You get an unconscious unresponsive call, or you have a patient who was stable and now went unconscious in the ED. It's kind of annoying to think, okay, like these are kids and these are priorities, and how do you prioritize? Like, yeah, you can call your charge, who can go for you. People are always willing to help, but it's just frustrating, especially too when you get on the pediatric units. We have a whole scoring system for severity on kids, and it's a protocol that allows us to either compress treatments or stretch treatments. So as kids score certain ways, if the scores are better, after so many good scores, we can stretch them from like a Q2 to a Q3 or a Q3 to a Q4 and keep stretching them out so we don't have to do treatments as often. Or if they're getting worse, we can shrink them all the way down to like Q1s. If they're admitted pediatric patients. So having to handle, like, I guess my example is one night when I was still precepting, I was precepting in the ED, and we had the pediatric ED, the adult ED, we had the tower, and we had pediatrics, and we had one patient in PICU. The pediatric patients and the PICU patients were obviously like a schedule. At least I know the PICU and one of the pediatric patients was also like vest, like Q4 on top of whatever else. So it's like on top of getting calls to come here to do these Q20 times 3 treatments in the pediatric ED or racemic epi treatments in the pediatric ED, and then getting calls to the adult ED. If it wasn't for the fact that I had a preceptor and we were able to split to manage this, it would have been largely frustrating. And honestly, as a new grad who's not super comfortable yet, it's terrifying. So I definitely like the adult side better than pediatrics as far as what I've experienced of it so far. Supposedly when we get into our busy seasons, whoever has the adult ED will not be handling the pediatric side, and vice versa, which is a little bit of a relief. But that was one thing I really did enjoy my pediatric and my NICU and PICU rotations. But when my job is not just pediatrics are not just PICU or not just a pediatric ED, and now you're having to do all three of these and you're throwing more adult stuff on top of it, it's a little overwhelming and a little daunting. So as far as I've experienced so far, I'm not a fan of that. That may evolve. I'm pretty green, obviously, working, so that's just kind of my current experience there. So, which is kind of a big thing, because there was a period of time just recently that I was talking about, man, thinking about getting my NPS, like going for it, but now it's kind of like, I really don't know if I would like that or not. So we'll see how it goes. For now, I've mostly been on the adult floors side. And then, we help where we can in other places. We always call around. We always call to the ICU just to see. They always do like AM gases. So we can always call to see if we can help do sticks. We're not allowed right now to draw art line gases. You have to just basically be checked off on it. But anyone in the ICU who just needs a stick gas, if we can help, we try to help them out too, since there's usually 2 therapists there, and depending on how many vents they have, and there's suctioning protocols now, and all the other stuff going on, so we try to help them out where we can. So getting a little bit of ICU experience. I got a little bit of post-critical care experience. Basically, there's 3 levels, like from the ICU down. ICU and then intensive observation, which is usually a closed unit unless there's just a lot. They kind of treat it more like an ICU overflow. And then down from that, they have the post-critical care unit, which usually still has a lot of like BiPAPs, a lot of heated high flows going on. And then from there, you kind of hit the general floors. So getting a little bit of experience there. Right now, I think I'm comfortable on the floors. I'm still kind of managing my different loads. Sometimes you have a lot of Q4s or Q6s. Sometimes you don't have as many Q4s, Q6s, but you have like a ton of BID, QIDs. And so for us overnight, BID, QIDs are only once. So it's kind of just depending on how, you're either front loaded or back loaded, you just manage it the best you can. And I'm kind of comfortable there now. I assume eventually I'll be comfortable to the point where I can get it done really quick, really efficiently, managing all my checks, if I have a heated high flow, if I have BiPAPs, all that stuff, get it all managed correctly. So, and so far I think my charting's okay. No one's said anything to me about anything being totally messed up. But it's little things too. Remembering to chart everything you do. Give yourself credit for your stuff. If you go and suction a patient who, let's say, wasn't one of your scheduled treatments, but it was in one of your units, nurse calls, asked to, I think we need some suction. You go in there, okay, you need to NT suction this person. So you go and NT suction. I'm like, don't forget to chart that, not just for liability's sake, but, give yourself the productivity. What were you doing in that time where maybe you had downtime, you weren't doing treatments or whatever? Like, absolutely, like, go and chart that. Don't forget to chart that. I think I've forgotten to chart one thing once. And it was just, I think it was a suction or something, or remembering after the fact, like hours later, like, oh, I did a blood gas and I never charted it. So then you're trying to go back and figure out what time, and you got to be pretty good with times. I've been really, really good about my watch that I wear to the hospital. It's synced within probably 30 seconds of the hospital clock. So I use it a lot, and I chart my time in and out. As soon as I walk in a patient's room, what time was it? Or what time did I leave the last patient's room? And I just boom, 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 and I try to keep track of myself. So I always have an idea of what time. So get used to always looking at the time, write down the time on your sheet a lot, keep track of when you're doing stuff, when you leave a patient's room, when you enter a patient's room, what time you scan the meds. Just keep track of time, and it helps you really go back. And so if you did it like me, you did a blood gas or you suction someone, you're like, oh crap, you remember like, at 6 a.m. or whatever, like, I got to chart that. What time did I do that? You can go and be like, okay, well, around this time, I was doing that treatment, and I know I did it after that, so you can go back and kind of figure it out. So anyways, guys, I'm going to stop it here. Hopefully it's not too long. I'll try to edit it down a little bit, so it's not too long, but hopefully gives you kind of an idea of what it's like to start working as a new grad for all the students out there. hopefully gives you a little insight. You know, don't take any of your experiences for granted, and know that when you hit the ground running, when people say they want therapists who can hit the ground running, they usually mean the respiratory side of things. You don't want to have to be. It's one thing to be reminded again how to set something up you've never set up before, or like something really confusing like, hey, I have to use this vent to set up BiPAP on a trach patient, and I want to make sure I do it right. You know, that's one thing to ask for a little guidance, but hit the ground running, guys. You know respiratory when you graduate. Don't stress out. If you have a good team, they're always going to be there to help you. You can always call them and ask questions. Your charges are great resources. Your experienced therapists are great resources. And don't be stressed, because charting will be different, and I promise you, everyone will chart differently. There's no right or wrong as long as it's getting done. I feel like to a point is how it is. So anyways, guys, everyone take care. Thanks so much for watching, and I'll talk to you guys soon.